Hi, my name is Alan Grill. I'm a family physician and the Provincial Primary Care Lead at the Ontario Renal Network. Today, I'm going to speak about KidneyWise, a chronic kidney disease clinical toolkit for primary care. I also want to mention that I have no financial conflicts of interest to declare. This slide lists the objectives for today's talk. The first objective is to recognize and predict which patients in a typical family practice are at highest risk for chronic kidney disease, or CKD. This is known as identification. The next objective is to clarify which investigations to order when screening for CKD and how to interpret the results. This is known as detection. The third objective is to describe the role of the primary care provider in managing patients with CKD and the criteria for appropriate referral to nephrology. This is known as management. And finally, the fourth objective of this talk is to introduce the Ontario Renal Network KidneyWise Clinical Toolkit that summarizes the above and promotes a model of shared care. The next slide talks a little bit about the Ontario Renal Network. The Ontario Renal Network is responsible for overseeing and funding the delivery of CKD services across Ontario. To read more about the Ontario Renal Network, you can look up the Ontario Renal Plan 2, which is a roadmap that outlines how the Ontario Renal Network will try to improve the lives of those living with chronic kidney disease. One of the main priorities of the Ontario Renal Network is to improve the early detection of CKD and delay the progression to end-stage renal disease, while improving access to care and nephrology services for those living with more advanced CKD. The next slide is going to introduce the definition of chronic kidney disease. This definition that you see before you is from the 2012 KDIGO Chronic Kidney Disease Guidelines. KDIGO stands for Kidney Disease Improving Global Outcomes, and it is an international organization that produces guidelines on chronic kidney disease every few years. Chronic kidney disease is defined as abnormalities of kidney structure or function present for greater than 3 months with implications for health. The key point of this sentence is you have to have these abnormalities for at least 3 months in order to make a diagnosis of chronic kidney disease. I'll speak more on this in detail a little later on. The thing about the KDIGO CKD guidelines is that they really do not target primary care providers. These guidelines were mainly written for nephrologists or kidney specialists, and so part of this talk is to clarify what these guidelines actually mean for primary care providers. Let's take a look at the criteria for CKD. The first criteria talks about albuminuria, which means protein spilling into the urine. If you notice in brackets, there's 2 different values that are given for albuminuria. This begs the question, should you be ordering a 24-hour urine on patients that you suspect have chronic kidney disease? Or is it just okay to order a urine ACR, which stands for albumin to creatinine ratio, when you're looking to diagnose chronic kidney disease? This isn't clear from this slide. The second point is urine sediment abnormalities. So does this mean you have to order a urine sample on every patient that you suspect has chronic kidney disease? This question will also be answered in a few slides. The next criteria is electrolyte and other abnormalities due to tubular disorders. Again, does this mean we should be ordering electrolytes on every patient we suspect to have chronic kidney disease? It continues to list other factors such as abnormalities detected by histology, which usually occurs with a kidney biopsy, structural abnormalities detected by imaging, for example, a renal ultrasound, and finally, a history of kidney transplantation. But to summarize, it is unclear from this list which tests a primary care provider should order when they're suspecting chronic kidney disease. The second criteria for chronic kidney disease is a decreased GFR, or glomerular filtration rate. This is pretty straightforward. A GFR of less than 60 mils per minute, by definition, is chronic kidney disease, if the result repeated in 3 months is still abnormal. Again, the next few slides will clarify exactly how to diagnose chronic kidney disease in the primary care setting. This next slide focuses back on GFR, which was referred to in the previous slide. If you notice, there are 6 categories of chronic kidney disease based on GFR. What's important here is that in isolation, a GFR greater than 60 is not considered chronic kidney disease. So patients that fall into stages 1 and 2 based on GFR alone do not have CKD. For primary care purposes, focusing on stages 3A and 3B is very important. In this situation, the GFR result, or estimated GFR, which is the blood test that you order on patients, that falls between 30 and 59 is considered chronic kidney disease. The majority of patients in primary care that you diagnose with chronic kidney disease based on the GFR level will fall into these two stages. The information from this talk will guide you on how to manage these patients moving forward. If a patient has a GFR less than 30 mils per minute, which puts them in CKD stages 4 and 5, they have a more advanced form of chronic kidney disease and should be referred to a nephrologist for consultation. This next slide talks about albuminuria, which was also referred to in the KDIGO definition of CKD. If a patient has isolated albuminuria consistent over 3 months, that patient can also have CKD regardless of their eGFR value. In this situation, KDIGO defines CKD based on albuminuria when you have a urine ACR, an albumin-creatinine ratio, greater than 3. This represents the A2 category. It is also important to know that on this slide, there are 3 different values for albuminuria. One is a value based on a 24-hour urine collection, and the other 2 have different units. One is defined as milligrams per millimole, and the other is defined as milligrams per gram. For the purposes of primary care practice, it is most important to emphasize that the test you should order to diagnose chronic kidney disease is a urine ACR, or albumin to creatinine ratio, which is the middle unit shown here in milligrams per millimole. It is not recommended to order a 24-hour urine in the primary care setting for 2 reasons. First, a urine ACR is a much easier test that can be done with the patient in your office or at a lab, and does not require a 24-hour collection of urine, which is a more onerous task for a patient. Secondly, the interpretation of a 24-hour urine is not straightforward, and patients often do not follow instructions properly when they are asked to do it. Therefore, it is recommended to leave that test up to the nephrologist should your patient require consultation at some point, and have the nephrologist explain in detail why that test is necessary and how to follow the instructions properly. The categories for albuminuria for chronic kidney disease by KDIGO are defined here. There will be more information to clarify the significance of the urine ACR result later in this talk. To summarize, in isolation, if there are 2 values of urine ACR greater than 3 milligram per millimole over a 3-month period, the patient has chronic kidney disease. This next slide comes from the Canadian Diabetes Association, and it also speaks to albuminuria. What's important to notice here is that this slide has a cutoff of 2 milligrams per millimole to define chronic kidney disease in isolation when you're ordering a urine ACR. This result is different from KDIGO, which was mentioned in the previous slide, as having a cutoff of 3 milligrams per millimole. The Ontario Renal Network KidneyWise Clinical Toolkit uses the cutoff of 3 milligrams per millimole to define chronic kidney disease based on albuminuria, as opposed to the cutoff of 2 milligrams per millimole as defined by the Canadian Diabetes Association. The main reason for this has to do with uncertainty about the accuracy of the urine ACR test at lower levels of albuminuria, coupled with concerns about overdiagnosis and labeling patients unnecessarily with CKD. It is important to note that aside from this latter point, the information regarding management of patients with diabetes and CKD in the KidneyWise Clinical Toolkit, which will be discussed in detail later in this talk, is concordant with the Canadian Diabetes Association guidelines. This next slide talks about why chronic kidney disease should be important to primary care. This is an important thing to discuss, considering the amount of information that primary care providers, both family physicians and nurse practitioners, need to know in order to deal with their patients on a day-to-day basis. With many different chronic diseases competing for the time of a primary care provider, it is important to emphasize here why chronic kidney disease should also be a priority within primary care. For starters, 90% of patients that you diagnose with chronic kidney disease will be at a low risk for progression to end-stage renal disease and can be followed and managed by primary care providers, either family physicians or nurse practitioners, depending on where you work in Ontario. Secondly, early identification of patients with chronic kidney disease and early intervention can prevent or delay the progression to advanced chronic kidney disease or even end-stage renal disease. Remember that patients that end up with end-stage renal disease or stage 5 CKD, based on the EGFR categories that was referred to earlier in this lecture, may need renal replacement therapy, which will consist of either dialysis or renal transplant. The goal of primary care should be to try and prevent these situations from happening with their CKD patients in order to keep their disease stable. Furthermore, primary care providers are very proficient in managing comorbid cardiovascular diseases such as diabetes, coronary artery disease, and congestive heart failure, and there is a direct correlation between cardiovascular disease and chronic kidney disease. So for all of the patients that are diagnosed with chronic kidney disease, it is very important to manage their cardiovascular risk factors. Finally, there are going to be some CKD patients who progress that will require consultation with a nephrologist. It is very important for primary care providers to identify these patients early in order to get them access to nephrology and get the extra care that they require to manage the complications of advanced CKD and potentially prepare them for end-stage renal disease. This next slide talks about the history behind developing the KidneyWise Clinical Toolkit for primary care. In 2012, the Ontario Renal Network did a primary care provider needs assessment in the area of chronic kidney disease. The respondents, who were primary care providers, reported back to the Ontario Renal Network that they were interested in improving their knowledge of chronic kidney disease. They specifically asked for access to reference tools and decision aids that were centered on evidence-based clinical practice guidelines for CKD. In 2013, after analyzing the above data, the Ontario Renal Network did an environmental scan to review which clinical toolkits or guidelines were available for chronic kidney disease targeted to primary care providers. This scan revealed that there was a significant gap, and in response, the Ontario Renal Network created the Chronic Kidney Disease KidneyWise Clinical Toolkit for Primary Care, which we will now review. This slide emphasizes the fact that when the KidneyWise Clinical Toolkit for Primary Care was being created, it was very important that the information was consistent with other guidelines related to CKD management that are familiar to primary care providers. Specifically, our toolkit references the following guidelines listed here. This next slide outlines the various components of the KidneyWise Clinical Toolkit for primary care. The first part of the toolkit consists of a clinical algorithm that helps with the identification, detection, and management of patients with chronic kidney disease, and it also guides which patients may benefit from referral to a nephrologist. I will be going through this algorithm in detail in the next few slides. There is also an evidence summary that offers further clinical details regarding the algorithm content, including references to clinical guidelines that were used in the development of the toolkit. This evidence summary is available online and can be read in detail after you finish watching this presentation. Finally, we've created an outpatient nephrology referral form that not only provides referral guidelines by outlining clinical scenarios that would require consultation with a nephrologist, but it also suggests appropriate investigations that should accompany each referral. This outpatient nephrology referral form is also available on our website and can be incorporated into electronic medical records for ease of use in primary care practices. This next slide gives a snapshot of the clinical algorithm associated with the KidneyWise Clinical Toolkit. I am now going to break down each part of this algorithm and talk about it in detail. To note, there are 3 parts of this algorithm: identification, detection, and management of chronic kidney disease. This next slide focuses on identification. There are 3 groups of patients that have been identified as being at elevated risk for chronic kidney disease. These three categories of patients are those with hypertension, those with diabetes, and patients aged 60 to 75 years old with cardiovascular disease. That includes coronary artery disease, congestive heart failure, stroke, or peripheral vascular disease. Regardless of age, hypertension and diabetes are the most common risk factors for CKD. It is also important to note that the presence of cardiovascular disease alone without comorbid hypertension and/or diabetes is not only less common, but as an independent risk factor, it is not as significant a predictor of CKD. Once a patient turns 60 years of age, their risk of developing CKD by virtue of age alone increases significantly. However, to avoid overscreening while being mindful of healthcare resource utilization, the ORN modified this age risk factor to include patients with cardiovascular disease. This not only will reduce the number of CKD screening tests ordered, but it will still capture patients with cardiovascular disease who may not have associated hypertension or diabetes, an important population to test for CKD. The ORN chose a cutoff of age 75 years and older to emphasize caution when considering screening elderly patients for CKD who may have a limited life expectancy. It is likely in these patients that a new diagnosis of CKD will not have a significant impact on their mortality risk. It is also important to note that this identification category is not extensive. There are other categories that you may read about that also put patients at risk for chronic kidney disease. For example, family history of end-stage renal disease, as well as certain systemic conditions like lupus, are also associated with a higher risk of CKD. However, the ORN felt they wanted to identify the categories related to population health that were most relevant within primary care, and therefore it is the above three categories that we added to the toolkit. The next category is detection. I will use the next slide to explain this in more detail. There are two tests that should be ordered to detect chronic kidney disease. The first test is a creatinine, which also comes with an eGFR, or estimated glomerular filtration rate, in most labs in Canada. This is a measure of kidney function. The second test that should be ordered for all the patients identified as having risk factors for chronic kidney disease is a urine for ACR, or urine for an albumin-creatinine ratio. This is a measure of kidney damage or injury, and as mentioned earlier, measures the amount of protein excreted in the urine. These are the only two tests that the ORN recommends to diagnose patients with CKD who are at elevated risk. It is also important to note that when testing for patients who are at risk for chronic kidney disease, it should be done in the absence of an acute intercurrent illness. For example, it would not be advisable to try and diagnose chronic kidney disease in a patient who presents to your office with dehydration or volume depletion. The reason for this is that there can be low eGFR values in such scenarios that might be reflecting an acute reversible kidney injury, or AKI, as opposed to chronic kidney disease, and this AKI will require a more rapid evaluation and a different workup. This next slide talks about what to do with the results. So, if you order an eGFR and a urine ACR on a patient that you've identified as being at elevated risk for chronic kidney disease based on the KidneyWise algorithm, the first result has to be abnormal in order to identify patients that may have CKD. So assuming that they do not have an acute intercurrent illness, if your first test of an eGFR is less than 60 mils per minute, you have to repeat the test in 3 months in order to make the diagnosis of chronic kidney disease. The same goes for a urine ACR. If the urine ACR is greater or equal to 3 milligrams per millimole, you also have to repeat that in 3 months in order to determine if a patient has chronic kidney disease. Specifically for the urine ACR, if you repeat the test in 3 months and it's normal, you would then be recommended to repeat it again 2 weeks later, because you need at least 2 out of 3 abnormal values to make the diagnosis of chronic kidney disease using urine ACR. With respect to the eGFR, if you get an eGFR result that is abnormal, which is defined as less than 60 mils per minute, but it is a surprising result or one that you were not expecting, you may not want to wait 3 months in order to repeat the test. For example, if you had a baseline eGFR that was ordered in the past, having nothing to do with diagnosing a patient with chronic kidney disease, and then when you screen this patient for CKD due to their risk factors, the eGFR result is significantly lower than the baseline eGFR, you might want to consider an acute process or an acute kidney injury that's causing this result. The main point of this slide is that you still want to use your clinical acumen to determine if your first result that is abnormal could wait 3 months to be repeated or if a more urgent workup is required. So, as a reminder, if you get a first result eGFR or urine ACR that is abnormal, one test is not enough to diagnose chronic kidney disease. The abnormal results need to persist for at least 3 months and have to be repeated at that time in order to make the diagnosis. If, however, the first urine ACR result or eGFR result is concerning to you, always consider reversible causes prior to retesting. For example, consider the following possibilities. Is the patient using over-the-counter NSAIDs or non-steroidal anti-inflammatory drugs that might be affecting the test results? Is the patient using a herbal remedy that might be affecting the test results? Has the patient recently gone for a diagnostic imaging test and the use of contrast dye has affected the patient's renal function? Has the patient recently suffered from a gastrointestinal illness resulting in vomiting and/or diarrhea that can affect these test results? And finally, does the patient have an enlarged prostate, causing them to suffer from urinary retention? If any of these are suspected, you should be repeating these tests earlier than 3 months to rule out an acute kidney injury. It is also important to mention again that renal ultrasounds are not recommended as routine tests to diagnose chronic kidney disease. This is due to the fact that often the results of these tests do not help with the diagnosis, and interpretation results can lack consistency. However, if a renal ultrasound is an appropriate test to rule out an acute kidney injury, as mentioned above, then ordering this test is absolutely appropriate. This next slide talks about how to make the diagnosis of chronic kidney disease at the 3-month mark. I will be breaking this down into 3 boxes: Box A, Box B, and Box C, as illustrated by this diagram. The first box we will review is Box C. So just to recap, this is where you have a patient that you have identified as high risk for chronic kidney disease based on the risk factors that were talked about earlier. You have then gone ahead and ordered an eGFR and a urine ACR, and these initial results have either both come back abnormal or one of them has come back abnormal. There was no intercurrent illness present, and you are not concerned about any other acute kidney injury. You have now repeated the tests 3 months later, and the results have both come back normal. The eGFR is now greater than 60 mils per minute, and the urine ACR is less than 3 milligrams per millimole. As a reminder, if your first urine ACR was abnormal, and now you have a normal urine ACR, please repeat the urine ACR 2 weeks later just to confirm it continues to be normal. In this scenario, the patient does not have chronic kidney disease. The key question now is, when do you follow up on another test for this patient who remains at high risk for chronic kidney disease? This answer is also somewhat arbitrary. If you look at the KDIGO guidelines, they give very detailed information on when to follow up a patient who is at high risk for chronic kidney disease. The Ontario Renal Network wanted to simplify this for primary care providers, given how busy your schedules are, and we have decided the following. For patients with diabetes, you should retest them for chronic kidney disease at least annually. For all other patients, repeating the test for CKD can occur less frequently unless clinical scenarios dictate more frequent testing. Although this is not clear-cut, we leave the decision up to you depending on the relationship you have with your patient. Again, I want to emphasize that you want to avoid labeling a patient with chronic kidney disease unless you confirm that result 3 months after the original abnormal test. This next slide represents Box B. Again, just as a reminder, this is where you have a patient that you have identified as being at high risk for chronic kidney disease. You have ordered a urine ACR and eGFR, and either one or both values were abnormal. You are now repeating the test 3 months later to determine if the patient has a true diagnosis of CKD. In this situation, either the eGFR comes back between 30 and 59 milliliters per minute, and or the urine ACR comes back between 3 and 60 milligrams per millimole. In this scenario, the patient has chronic kidney disease. The first thing you should do is discuss this diagnosis with your patient, and then you should order 2 more investigations: a urine for routine and microscopy, or R&M, and electrolytes. The urine R&M is ordered to look for microscopic hematuria as well as red blood cell casts that might indicate other forms of nephropathology, such as glomerulonephritis. Electrolytes are ordered to pick up any abnormality that may need to be addressed urgently, such as high potassium or hyperkalemia. If you have any questions about the results of these tests, if they come back abnormal, you should consult your local nephrologist for assistance. Furthermore, these patients need ongoing follow-up in order to monitor for any progression of their chronic kidney disease. Serial follow-up of eGFR and urine ACR is required every 6 months after the diagnosis is made. If the patient's eGFR value is stable for a 2-year period, you can decrease the frequency of monitoring to once a year. This next slide talks about what to look for as you're monitoring the patient every 6 months or every year, depending on the stability of their chronic kidney disease defined by their eGFR level. The following criteria listed here should be identified as reasons to refer to a nephrologist. For example, once a patient has an eGFR less than 60, and that eGFR declines by greater than 5 milliliters per minute within a 6-month period, it means this patient is at higher risk of progression towards advanced chronic kidney disease and should be seen in consultation by a nephrologist. This result should also be confirmed 2 to 4 weeks afterwards in order to make sure there was no lab error. Please take a moment to review the rest of this list. I will talk about some of the management steps you can follow in order to help prevent CKD progression, but should a patient meet any of these criteria, they should be referred for nephrology consultation. This next slide is box A, the final box to consider when you're making a diagnosis of chronic kidney disease. Just as a reminder, this is when you have a patient that was identified as high risk for CKD and their original eGFR and or urine ACR test was abnormal. You have now repeated the test 3 months later, and their eGFR result is less than 30 mils per minute, and or their urine ACR result is greater than 60 milligrams per millimole. In this situation, the patient has chronic kidney disease, and mentioned on the previous slide, because these values are significantly abnormal, they should be referred to a nephrologist. The other important thing to take into account with this slide is that when you are referring a patient for nephrology consultation, please do not lose the relationship with your patient. Just because the nephrologist is going to help you manage a patient with advanced or progressive chronic kidney disease, it should be considered a shared care model. The primary care provider is still responsible for the management of these patients' overall health needs. It is also important to work together and communicate with your consulting nephrologist in order to give your patient the best care with respect to their CKD. The next section in the KidneyWise clinical algorithm for CKD focuses on management. I will now take you through the 3 categories. The first category will focus on how to modify cardiovascular risk factors. Then I'll talk about minimizing further kidney injury. And finally, I'll discuss implementing measures to slow the rate of chronic kidney disease progression. This first slide talks about implementing measures to modify cardiovascular risk factors. Primary care providers are well suited to counsel their patients on how to modify their lifestyle by incorporating regular exercise and a healthy diet, as well as quitting smoking, which puts you at risk for cardiovascular disease. In terms of lipid management, the guidelines for chronic kidney disease differ slightly from the 10-year Framingham risk assessment tool that most of you probably use in your practice. The following CKD patient categories are at higher risk for cardiovascular disease and would benefit from statin therapy: To summarize these categories, if a patient with chronic kidney disease has diabetes and they are older than 18, it is recommended they start taking a statin. A discussion about pharmacotherapy, including side effects, should then take place with your patient. If a patient does not have diabetes but still has chronic kidney disease and they are older than age 50, they should also be recommended to start a statin. And finally, for patients without diabetes but who have chronic kidney disease that are between the ages of 18 and 49 and also have known coronary disease, a prior stroke, or their 10-year Framingham risk is greater than 10%, they should also be recommended for statin treatment. For patients with chronic kidney disease who also have diabetes, it is important to reach the appropriate target hemoglobin A1C level as defined by the Canadian Diabetes Association guidelines. Please refer to these guidelines for further information. This next slide just shows the correlation between chronic kidney disease and cardiovascular disease. If you notice, the x-axis represents eGFR and the y-axis represents the age-standardized rate of cardiovascular events. As the eGFR decreases across the x-axis, the number of cardiovascular events in the y-axis increases. This emphasizes that patients with chronic kidney disease need to be managed in terms of their cardiovascular risk factors in order to reduce their chance of having a cardiovascular event. The next slide regarding the management of CKD focuses on how to minimize further kidney injury. As mentioned earlier, please advise all patients with chronic kidney disease to avoid nephrotoxic medications, such as nonsteroidal anti-inflammatory drugs, or NSAIDs. As well, if patients are going for diagnostic imaging tests and require intravenous or intra-arterial contrast, please make sure the radiologist knows that they have chronic kidney disease, as sometimes using contrast in this population is contraindicated. If contrast dye is necessary for certain diagnostic tests, please consider reminding the patient to hydrate orally with fluids and to withhold diuretic medication, where applicable, prior to the test being done. Furthermore, in our evidence summary of the KidneyWise Clinical Toolkit, we have listed the sick day medication list from the Canadian Diabetes Association guidelines. This list of medications are to be avoided in patients with CKD if they get sick, specifically illnesses that cause vomiting, diarrhea, and volume depletion. Please refer to the evidence summary of the clinical toolkit for more information. And finally, for patients with CKD to whom you're prescribing medications, regardless of the medical indication, please remember to check whether the dose of that medication needs to be adjusted because of their decreased renal function. This final management slide for patients with chronic kidney disease in the primary care setting will focus on implementing measures to slow the rate of CKD progression. This slide will focus on blood pressure management as well as management of an elevated urine ACR, should it exist with the CKD patient. Let's start with blood pressure. For patients with chronic kidney disease who also have diabetes, their blood pressure should be targeted to be less than 130/80, as per the Canadian Hypertension Education Program, or SHAP guidelines. If a patient with CKD does not have diabetes, then their blood pressure should be targeted to be less than 140/90. In terms of urine ACR, if a patient has chronic kidney disease and they have diabetes, and their urine ACR is greater than 3 milligrams per millimole, then they should be started on an ACE inhibitor or an ARB. Please note that for patients with chronic kidney disease and diabetes and an elevated urine ACR, it is recommended to use either an ACE inhibitor or an angiotensin receptor blocker to treat their elevated urine ACR regardless of their blood pressure measurement. However, if this diabetic patient with chronic kidney disease and an elevated urine ACR already has their blood pressure at target or lower than target, one must use an ACE inhibitor or ARB cautiously in order to prevent a patient from developing orthostatic hypotension. Orthostatic hypotension can lead to falls as well as fractures, and it is important to weigh the risks and benefits of treating a diabetic patient with CKD for their elevated urine ACR before starting pharmacotherapy. If a patient who has chronic kidney disease but does not have diabetes and has an elevated urine ACR greater than 30 milligrams per millimole, in addition to their blood pressure being above target of 140/90, then it is recommended to start treatment with an ACE inhibitor or an ARB. Please note that in this scenario, you are choosing the ACE inhibitor or ARB in order to treat the patient's hypertension, and this class of antihypertension drugs is preferred over others due to the added benefit of treating the elevated urine ACR that is above 30 milligrams per millimole. If you have a CKD patient without diabetes who does not have an elevated ACR greater than 30 milligrams per millimole, but is still hypertensive, you have other choices you can use as a first-line therapy for high blood pressure as per the SHEP guidelines. You may still in fact choose an ACE inhibitor or ARB if the patient has other clinical indications, for example, known coronary artery disease or congestive heart failure. Please refer to those guidelines for further information. This slide is a snapshot of the KidneyWise Outpatient Nephrology Referral Form. This form can be accessed via our website, which I will talk about at the end of this presentation, and it can also be incorporated into an electronic medical record for ease of use. Please notice the features of this nephrology referral form. The top part of the form has a section on patient information that can either be completed electronically, by hand, or alternatively, your staff could produce a patient label or sticker to populate that section. In terms of recommendations and reasons for referral, we put tick boxes beside the most appropriate reasons to refer to nephrology, most of which were already mentioned earlier during this presentation. There's also an area where you can put additional comments should you request a consultation for another reason. We tried to include common comorbid conditions on the form that could simply be checked off. Obviously, providers could attach a separate list of relevant past medical history if applicable. In terms of lab values, these can be attached to the referral form as a separate page, or they can be pre-populated electronically using your EMR. The medication list can also be entered on the face of this page or attached separately. And finally, the bottom part of the form just requires a signature, the referring practitioner's information, and billing address. This next slide focuses again on the reasons to refer to nephrology. Most of these reasons have already been mentioned earlier in this talk. The reasons that were not mentioned, as they may not relate to chronic kidney disease, include a metabolic workup for recurrent renal stones and treatment of resistant hypertension. So the outpatient nephrology referral form is not just for CKD patients, and we are really hoping that the majority of primary care providers in Ontario use this form to keep nephrology referrals consistent and appropriate. We are also speaking with our nephrology colleagues to make sure they are accepting the form when it is sent to them. Again, most patients who are at low risk for progression to advanced or end-stage renal disease can be managed by primary care providers and do not require nephrology referral. This referral form is just a guide and a list of the most appropriate indications for a referral to nephrology, but it's still expected that the primary care provider play a large role in managing their patients with CKD. So, in conclusion, chronic kidney disease testing should only be applied to patients at high risk of chronic kidney disease and in the absence of acute intercurrent illness. This is known on the KidneyWise clinical algorithm as identification. eGFR and urine ACR are the tests of choice for patients at high risk of chronic kidney disease, and this is referred to as detection on the KidneyWise clinical algorithm. Most cases of chronic kidney disease in primary care are low risk for progression to advanced CKD and can be managed exclusively by primary care providers. This is known as management on the KidneyWise clinical algorithm. But please remember to refer to nephrology as appropriate, as outlined on the outpatient nephrology referral form. The main reason for referral is to identify patients at high risk of progression that may require further management by the nephrologist. Finally, the KidneyWise Clinical Toolkit will make chronic kidney disease management easier for primary care providers and will empower all of us to improve patient outcomes related to CKD. The KidneyWise Clinical Toolkit is available on the Ontario Renal Network website at kidneywise.ca. There is also a link to download our interactive KidneyWise app, available for smartphones and tablets. Please try out the app. It is very practical, reviews all of the content of this presentation, and can be used while interacting with your CKD patients in clinic. If you have any questions about the KidneyWise Toolkit or about the content of this lecture, please email us. Our email address is kidneywise@renalnetwork.on.ca. Finally, I want to thank you for the time you took to watch this presentation. I also want to thank my colleague, Dr. Scott Brimble, for helping to develop this presentation and the KidneyWise Clinical Toolkit. Dr. Brimble is the provincial lead for the Early Detection and Prevention of Progression program at the Ontario Renal Network. He is also an associate professor in the Department of Medicine at McMaster University and a practicing academic nephrologist. This ends the KidneyWise CKD Clinical Toolkit presentation.